It's a nice opportunity to discuss on small renal masses with Alessandro Volpe. I'm very happy to interact with you on this very controversial topic, in my view.
Thank you very much, Professor. It's an honor for me as well, of course.
So when we start with diagnosis, what do you use as imaging tool preferably? Do you see any advantage of new technologies?
Well, as you know, the gold standard for the imaging of renal tumor is triphasic CT scans, so contrast-enhanced CT scans. Since we all know that the pathognomonic marker of a malignancy is enhancement. Of course, there is a lot of interest today with MRI, and especially multiparametric MRI techniques. However, at present, there is a lot of interest, but these new techniques don't seem to be good enough to differentiate benign and malignant tumors, while they seem to have better opportunity to differentiate among histotypes of RCC. Anyway, I think this will be interesting to discuss. Maybe there will be opportunity at the meeting.
Is it so important to have some kind of a pathological diagnosis beforehand?
Well, I think I'm a supporter, as you may know, of a percutaneous biopsy of renal tumor. I think that right now it's increasingly important to know our pathology about our pathology of renal tumors in some cases.
If you have a solid tumor, small renal mass is 2.5 centimeters. For me, it's a surgical tumor, unless it's an angiomyolipoma, which you will puncture.
I fully agree.
The only possibility is an oncocytoma.
Well, I fully agree with you that in young and fit patients, biopsy is not necessary in most cases. However, in elderly patients where the options are wider, and so there is surgery, but there is also the opportunity of minimally invasive ablative treatments and surveillance, I think that knowing the pathology can be helpful, because of course we will be much more inclined to follow a benign tumors or even a low-grade tumors compared to a high-grade one.
I'm a big favorite of biopsies, because either you're going to do something about the tumor, or you're going to watch just do active surveillance. But if you're going to do something, whether this is ablative therapy or whether this is surgery, either you treat or you don't treat. And the only reason for me to do a biopsy would be maybe in a patient that I might not treat. Then do a biopsy and say, okay, it's a tumor that we can follow.
I think that we agree on that because basically what I say that generally I recommend a biopsy when a patient that comes to my clinic is not a perfect surgery candidate. And then I want to know more about this tumor besides the patient characteristics in order to tailor the best treatment for that patient.
But you also like active surveillance, I understand.
Well, I'm not saying that I like. Of course, I've been involved in research in active surveillance. So we're working with Michael Jewett in Toronto. We had the opportunity to test for the first time prospectively surveillance in a small cohort of patients. But then after that, several other studies have been published. And now there is a multi-center Canadian trial which enroll many patients, showing that actually most small renal tumors grow slowly over time, and the tendency to metastasize is quite rare. If we do a proper surveillance over time and we are ready to intervene with delayed intervention for those tumors who show a rapid growth of developed symptoms.
Active surveillance is actually is a treatment modality, it's a management modality in patients that are too frail to have any treatment. But any treatment could be a percutaneous radiofrequency ablation that you could perform under local anesthesia. About every living man or woman could have this procedure without major risks. So there's very few active surveillance candidates in my opinion.
Well, of course, you are right that most patients generally they come to our clinic and they are fit and they are young and fit, but there are some elderly patients that are really unfit and the anesthesiologists are not happy to bring to the operating room, or there are more and more patients that are coming to our attention with other tumors, and they have been found with a small renal mass just during follow-up imaging of their tumors. And these patients are generally potentially good candidates for a surveillance approach.
If you then have a younger patient with a renal mass of 2.5 centimeters, it's a solid tumor, you're not doing any biopsy, you bring him to surgery, you do ablative therapies in these young men?
Well, in general, we always inform patients about all the options. If it's a young patient and fit, again, I also agree with you. I don't generally recommend a percutaneous biopsy. I offer also ablative treatments, but I have a clear idea that the gold standard is surgery, so these patients should get nephron-sparing surgery. And I think this is what we really know, and as we know from your study, this is the only level 1 evidence we have in kidney cancer. So we should always remove localized tumor with nephron-sparing surgery whenever this is technically possible, of course.
Yeah, focal therapy in my department actually is just performing patients that cannot have surgery or that need to have second surgery. What is your opinion about patients that have had primary surgery for maybe a multifocal clear cell renal cell carcinoma? They recur after 3 years, they have a lesion that you see grows then 2.5, 3 centimeters. You go back in, or you do ablative therapy?
Well, again, it depends on the patients, but I think that in these cases, especially patients with genetic or hereditary RCCs or multiple bilateral tumors, there is a window of opportunity for ablative therapies, I think, especially if they are already gone through previous procedures. So I'm in favor of that in general.
How do you follow up your patients after the first surgical attempt?
Yeah, I generally follow a strict follow-up, which actually we developed with a group in Toronto, Canada 10 years ago. So I generally follow this patient if it's a localized T1 tumors, T1A or T1B tumor. I just follow it with an ultrasound and chest X-ray at 6 months. And I generally do only one CT scan at 1 year follow-up. Other than that, I generally follow this patient every 6 months for the first 3 years with the ultrasound, and I don't repeat CT scan anymore. Of course, that's a different story for advanced tumors.
In papillary type 1 or in hereditary genetic determined clear cell, you do not do more regular follow-up?
Yeah, I'm a bit more aggressive in this patient, as well as in patients, of course, with positive margins at surgery.
So there's not too much differences in our opinions for diagnosis and management.
I'm happy about that. There are some, and that's the nice thing of evolution.
We'll further discuss that in the later.
We will further discuss. It was a pleasure.
Thank you very much.
Thank you very much.